Hi, welcome everyone to day two and our second virtual exhibit hall. We are so delighted that you're joining us today. We have the opportunity to see two companies today. The first one will be Videra Health, and that will be presented by Josh Talbot. The second company will be Otsuka Precision Health. They'll do an overview of Rejoin, and that will be presented by Coral Medina Silva as well as Brian Ampleman. So because we have limited amount of time, and I'm sure there will be plenty of questions, I would love for Josh to go ahead and hop into the webinar and we can get started.
Wonderful. Thank you so much, Lisa. And hello, everyone. Very excited to be here with y'all virtually this wonderful Tuesday afternoon. I'm gonna go ahead and share my screen. Okay, fantastic. So we only have 20 minutes, including Q&A. So going to have to try and go through this a little bit more quickly. Also, my first time doing a Zoom webinar of this sort. So if I sound a little funky or look a little weird, it feels like I'm talking to myself. So appreciate your patience with that. But thrilled to be here talking with you all, thinking about how we can turn video into vital signs using artificial intelligence, looking at a specific application within a neurodegenerative disorder called tardive dyskinesia, and then looking beyond that as well. So a little bit about me, actually University of Virginia alumni, so excited to be here at this particular conference. My life vision is to sustainably advance patient care through technology. I'm a computer scientist and data scientist by background. I've worked with health systems for the last 10 to 15 years, trying to identify where digital health can really help ultimately clinicians do more of what they love. I've also done a little bit of work with the FDA, helped build out their drug surveillance and adverse events platform. And then I've recently joined this company called Videra Health, spurred on by a family mental health event. And we're a human understanding platform. For those maybe a little bit less familiar, Videra is a passionate team of clinicians, scientists, and engineers who are developing observational biomarkers to deepen human understanding. So just in terms of a little bit of the context here and why are we in this space at all, what we found is that episodic care is a tough model to tackle the continuous lives that patients live. We're doing the best we can. I'm married to a clinician myself, but resources in our current care delivery models make seeing our patients longitudinally a little bit more challenging. So I want to kind of try and bring this to life a little bit and paint a picture too of a future world. So meet Miguel. He's a father of three, grandfather of seven, who has struggled with a major depressive disorder. After one such event, he's hospitalized and begins antipsychotic treatment. He stabilizes and does return home to his family, but a few months later, he realizes that he's got some uncontrollable facial movements and restlessness. He stops reading bedtime stories to his grandchildren, feeling more self-conscious and withdrawn, and he's finding that it's impacting his work too. So during a routine video-based check-in, an automated screening flags signs of tardive dyskinesia. His psychiatrist is alerted and schedules a follow-up. Miguel's treatment regimen is adjusted, adding more TD-specific care, and then within just a couple weeks, his symptoms ease and he's back to reading with his granddaughter at night with more confidence. So in Miguel's story, what we see is someone who is seen by that clinician, but is initially screened by video, which identifies the signals of TD and alerts his clinician, which leads to a more improved quality of life. So fortunately for Miguel, that future is actually here. It's just not easily distributed. One of the key reasons for that is anytime we're using technology in general, we want to make sure that there is pretty robust clinical validity. And so a couple of years ago, our team set out on a journey with our clinical team and our academic and clinical partners to validate that. And actually, the peer-reviewed journal article is coming out in the Journal of Clinical Psychiatry in September and was published online just last month. So a little bit of a kind of an overview of that. The goal here is to think about, how could we sustainably scale screening for tardive dyskinesia in a way that is validated and using machine learning to be able to do that. So our method was taking data from across three different studies. Video data was collected using a smartphone app that guided participants through a journey experience, and then the results from that data alongside evaluations from raters trained that learning model. And what we found is not only is the model and algorithm effective at not just identifying tardive dyskinesia, but also tagging the severity tied to that as well. So the conclusion here is we can reliably detect tardive dyskinesia, but then there's also opportunities to expand that video and conversational AI within other contexts, which is what we've been doing. So a little bit of kind of background and context. Tardive dyskinesia, kind of a long expression, and I imagine most folks here being in the academic and clinical world around psychology and psychiatry are quite familiar with it. But in case anyone hasn't come across it, it's a pretty serious and often debilitating neurological syndrome that's mostly caused by longer exposure to antipsychotic medications. It's not great. It diminishes patients' quality of life, compounds distress and cognitive impairment. In some cases, it can be mild, but it can also be really debilitating and is also usually irreversible. So early detection of this is actually pretty key, but is challenging for a variety of reasons. Even though 1 in 4 who are on antipsychotic medications may eventually develop TD over time, and it can onset within just 3 months of taking that medication. Really, only 15% of folks have been screened, and about less than 2% are on medications that help address it. And this is largely in part because only 80% or 80% of patients are not getting screened for tardive dyskinesia. And that's not, I don't think, anyone's fault. It takes someone who's skilled, like, do it much quicker, but can be up to 30 minutes to screen for tardive dyskinesia to perform the Ames assessment. And if we think about a lot of the other things that have been discussed here, the increase in telemedicine first care, increasing demand for psychiatric services, that just places more demand and strain on our already tapped healthcare workforce, and that often is at the expense of uh, time-consuming safety monitoring protocols like those for TD. So all that to summarize, despite the best attempts of folks like my wife and other clinicians who are actively trying to serve their patients. TD is typically usually only recognized after the involuntary movements become a little bit more permanent. So what we wanted to do in this study is think about how do we address the reliability of machine learning approaches that augment that initial screening of TD performed remotely. And so I'm sure that a question is probably percolating in the back of some folks' minds, which is, so is the bot doctor going to replace me? The answer is resoundingly no. This screening does not replace an in-person assessment by a physician. Um, just as initial screening, relying on the clinician for the definitive diagnosis and then subsequent management of the condition. So how does this work? We have a tool called TD Screen. It's a video-based AI-enabled solution to screen for tardive dyskinesia. I think there's a link at the bottom that you can go to for more information, but go through a series of guided questions. It takes about 5 minutes to get a video response, and then we do AI-based analysis to look at what's said, how it's said, facial expressions, any other movement that we're able to capture, and then from that can screen for tardive dyskinesia, and then also for other observational biomarkers, anxiety, depression, as represented on the right-hand side here by PHQ-9, GAD-7. So anyway, a lot. Gonna take a deep breath and pause before moving on. No questions right now. We'll save those all the way at the end for Q&A, but just to give a 5-second brain break before moving on. All right. So what did the study actually look like? There's three parts to it. In the first and in the second, participants completed the Ames procedure. They're sitting across from a device on a stand rather than the assessor. So in all of the studies, the abnormal involuntary movement scale was delivered in a clinical setting. And again, in those first two, using a device on a stand, clinician in the room. For study one, following the Ames, individuals responded to 6 open-ended questions. You can see one example here. In study two, we narrowed that down to 3 open-ended questions and expanded the sample size. And then in the last study, We kind of broke that down and simplified it a bit into three different steps. Um, Tapping, 15 seconds of tapping a hand on the shoulder, 30 seconds opening the mouth and sticking out the tongue, followed by sitting still for 30 seconds, and then answering two open-ended questions. And then importantly, in all of these, of course, followed IRB guidelines, and all studies began with obtaining informed consent from all the participants, going through this, smartphone app guided video experience to make a more standardized protocol for this. For anyone interested on kind of the guts and the back end behind it, predominantly using mathematical transformers with what sat behind this as well. I'm glad to go into additional detail for folks who may be interested here offline. If you think about what does this look like from the provider perspective, they're able to see the full replay of that video as long as key responses from the patient. If they look at the individual patient, and then you can also see kind of more of a dashboard view of the alert itself, a little bit of a summary, and then kind of some of the signals that are coming out from this video experience as well. So as we think about kind of the performance that we see here, there's a metric within kind of this model world called area under the curve, or AUC. Typically, a score closer to 1 is better. Anything higher than 0.85 is strong performance. And so we were excited that the whole research team was that we landed at an AUC of 0.89 and distinguishing between a positive and negative case. And then as we look at kind of sensitivity and specificity, sensitivity just being how well it measures the positive cases, and then specificity on how well it identifies negative cases, and thinking about how we identify that threshold was around 0.82, 0.81. That also is another way of helping assess kind of the algorithmic accuracy as well. So that's a little bit of kind of the results. So we think about, okay, well, what does this mean? It's quite interesting. So what it means is that there's opportunities to think about AI within video AI for screening purposes within a more clinical context and setting. And what we found is that that's kind of one area that video and conversational AI can be useful across the patient journey, and in an attempt to try and deepen human understanding. But there's also other ways. Workflow automation is one that I think has been discussed and talked about in different ways through, for example, ambient AI scribe note taking. Candidly, a little bit more of a commodity. At this case, I think there's 127 or so ambient scribes that are operating in clinical contexts and settings, and that number continues to grow on a regular basis. We've also developed kind of ambient scribing tools and to do individual and group therapy notes with speaker identification and whatnot. But then workforce optimization is another piece. With a lot of the leaders of different health systems and behavioral health centers that we talk to, thinking about how you reduce burnout, how you reduce turnover is really key for a lot of them. And also, how do you think about making sure that everyone is operating at top of licensure? If you're a CEO, you have no idea necessarily once your clinician gets into the room with a patient how that went. And so I'll touch on one example of how we've extended this kind of video and conversational AI platform into that world. So we've developed a product called Sidekick Elevate, which kind of sits in on the room in a conversation between a patient and provider, obviously with consent provided, to really look at what's the interaction between the patient and provider. So we look at therapeutic alliance. We look at how well empathy was built. Were teach back techniques employed? What type of trust was used? You can see in this particular illustrative example, the clinician was speaking more than 5 grade levels apart with the patient. And so that is going to not help as you're thinking about therapeutic alliance. And this is some thinking about how you can more effectively handle the qualitative nature of patient-provider interactions is top of mind for a lot of folks. And so this provides a way, using that same chassis as a tardive dyskinesia screener of conversational and video AI, applied to thinking about some of those components too. So that's just kind of a small illustration of other areas where this can be applied. So I think I want to close and just thinking about the sort of safety and efficacy of a lot of this. So for most of us, we have either our own or someone that we love dearly journey through this. And so as I think about my own and my family's experience within mental health, the idea of the robot will see you now is not personally palatable. I know others may hold different opinions there. And so how do we think about, with the increasing proliferation of AI-enabled solutions within behavioral health, and mental health, how do we think about that responsibly? And so if you come away from this conversation with one thing, it would actually be model cards. Model cards are what a way to assess the efficacy um, of an AI-enabled model. So if you don't have a model card, it's a black box. And if it's a black box, that exposes you, your organization, the other clinicians you're working with, and your patients to potential clinical risk. So ask about model cards. Typically, you'll have to sign an NDA because it's often the secret sauce behind a lot of these applications. But that's kind of a key one. Clinical validation is another piece as well. Having some type of study or ideally peer-reviewed published article, something that substantiates this beyond just shiny tech is super important. And that bleeds into the next point here around regulatory and ethical standards. And then regular monitoring and updates is really key. As you've probably seen, most of us hadn't used AI in our everyday lives 3, 4, even 2 years ago. And so this space moves fast. And so you want to make sure that anyone that you're working with is providing regular updates. You obviously want to make sure that there's clear ROI here and clinical impact and not just a sort of, shiny new tech exploit. And that anyone that you're working with is willing to kind of go in the trenches with you and connect on a more regular basis to make sure that whatever they're providing meets the inevitable demanding needs of the patients and the clinicians that you're working with, or if you are a clinician yourself. So that I think wraps up kind of a few of the things that we wanted to talk through. Now that was super fast. I want to make sure that I gave our friends at Otsuka some time. So we maybe have just 2 or 3 minutes for some questions here, which I'll try and answer. And any that we can't get to can try and think about how to answer offline as well.
Josh, that was a wonderful presentation, and there's so many questions coming in. I don't know if we'll be able to capture them all, but I will say, as a clinician, pharmacist, TD, it was something we struggled with our patients, taking antipsychotics 30 years ago. This was something,
Yeah.
and we're still trying to wrestle with it. So I appreciate this. Again, looking at the questions, we have several coming through.
Mhm.
So when you think about the product, where do you see the best opportunities and then challenges to engaging patients and providers in using this screening tool?
Mhm. Yeah, I mean, I think the biggest thing is probably just awareness. Most folks who have family, friends, or loved ones who are struggling with tardive dyskinesia want to be able to have some type of resolution or tool. But candidly, even tardive dyskinesia itself is not as well known among even the clinical community. And so I think that the biggest opportunities, David, are probably in just honestly, this is kind of a meta answer to your question, but just raising awareness. So that can take a few different flavors. I think once people actually use it from either the provider side or the patient side, really high engagement. Folks are really excited, but it's just getting the word out there that hey, this tool actually exists. We actually offer this for free. I should have mentioned that. TD Screen is not because we are a AI platform. We are able to make money in other ways, and so we don't charge at all for TD Screen. So if you're a practicing clinician, you can just use it for free within your practice. And so for that, it's people are engaging with it once they know about it. It's really just a question of like, do they actually know about it?
Okay. Well, I think after that last comment, we might have some additional questions about the
Yeah,
it being
yeah,
for free, but that's very noble because in practice, it's something that
yeah,
we have to look at. Um,
yeah. And just real
another
quickly, my email is super simple. It's just josh@viderahealth.com.
Okay,
Yeah,
and we'll send that out too.
great.
Um, Another question came through about you touched on therapeutic alliance. How do you actually measure that?
Yes. The short answer is we did a study with an academic medical center to basically develop that quantitatively. If helpful, glad to connect separately on a little bit more details of kind of what goes into that. But it's a great question around, isn't it stressful for clinicians? Yes. And in particular contexts. Where we found this to be most effective is often in more training programs, so fellowships, residencies, if you're on the psychiatry track.
Mhm.
There are also other instances where a provider system might do it every once in a while. Um, I think one thing that we're seeing is it's depending on how it's packaged too, right? If it ends up just being something that you're able to see as your own clinician, that's one thing. If it's something that gets reported all the way up to your boss, that could potentially have, there's some deleterious implications there. And so it's a great question, and one that I think as a leader of a health system or behavioral health organization, you'll have to think about being somewhat judicious in where you'd roll it out.
Sure. Another question was, do you only focus on TD or do you have other screening tools? And maybe they're in development.
So yeah, we wanted to focus on TD just for the purpose of this talk, but no, yeah, our screening tools, we're a human understanding company that is developing kind of video and conversational AI for observational biomarkers. So TD is one of them. We have screeners for anxiety and depression. We're also working on ones for Alzheimer's and bipolar, Parkinson's as well. And then we have a roadmap for a much broader set of conditions too. So yeah, if you're interested in learning about more of that, most of our customers and partners that we're working with are using our platform to check in with patients after discharge. So if you're discharged from an SUD facility, for example, residential facility, you want to check in with that patient on a more regular basis. You can set up a program with us to send them a 60-second video question, cover the last 2 weeks for you. And from that 60 seconds of video, again, with about 90% accuracy, can discern anxiety, depression, suicidal ideation, things like that. So,
Okay. Well, great. We're running out of time, so I apologize. We'll send the questions over to you, and we will post your email in the chat feature. So,
yeah.
With that, thank you so much. I know you can't hear the applause, but yay, good job.
Yeah, no, my pleasure. Please feel free to reach out, and glad to answer more questions later too.
All right, thank you.
All right, cheers, everyone.
Thank you. So next up will be Otsuka Precision Health. They will be joining us to provide an overview of Rejoin.
All right.
Thank you, Lisa, for turning it over. Brian Appelman, I'm the Market Development Executive here for Digital Therapeutics with Otsuka Precision Health. And just wanted to take some time to thank the Society for Digital Mental Health and just all the great experiences that we're having already, the robust conversations. I think this is an endeavor that we're all taking on together. Love the panel today and a ton of those conversations and discussions and really just what we're facing today in the market. And I'm going to turn it over to the star of the show, Corral Silva Medina, who's going to go over the clinical aspect of Rejoin to provide you with that information. I am merely here as just arm candy and to answer any questions that she can. So with that, I'll turn it over to Corral.
Thanks, boss. Hello, everybody. My name is Coral Silva Medina. I'm the Digital Health Engagement Partner for the Southeast. I'm a doctor of clinical pharmacy, and it's my pleasure to bring that perspective as I kind of introduce Rejoin today. Let me go ahead and share my screen with y'all. Hopefully. Right. So let's jump right in. So what we have, Rejoin is a prescription digital therapeutic for the treatment of major depressive disorder, indicated for adults 22 years and older who are on concomitant antidepressant treatment. Please note, of course, the pharmacist in me has to start with the safety information. Rejoin is indicated as an adjunct to outpatient care, and it's not intended for standalone therapy or as replacement to medication. Additionally, Rejoin does not monitor the patient's symptom or any changes in their clinical status. That being said, providers must instruct their patients to either contact them or seek immediate medical attention if they believe that their depression is worsening or if they feel that they may be a harm to themselves or others. Major depressive disorder affects an estimated 21 million adults in the US each year. We know that depression can start early in life and it can be chronic, imposing severe burden on the patient's quality of life. There are a wide range of therapeutic options available to practitioners. There's first-line approaches, antidepressants, psychotherapy. We've got select augmentation strategies. And despite this, there remains a large need for additional treatment approaches. To this effect, the NIMH called for the development of novel treatments with particular focus on clinical validity, accessibility, as well as the focus on all sets of symptoms, not just some, right? Cognitive, emotional, and behavioral. Otsuka's innovative response to that was the development of the prescription digital therapeutic of sound neurobiological rationale and robust clinical backing. Our PDT was submitted to the FDA via the 510(k) regulatory pathway for comprehensive and highly scrutinous review of safety and performance data. In April of 2024, we obtained that regulatory clearance, and in doing so became the first and only FDA authorized prescription digital treatment for MDD symptoms. Notably, as I mentioned at the beginning, so FDA device regulations define the pediatric population as anyone less than 22 years of age, which is why Rejoin is indicated as adjunctive use in adults 22 and over. As our understanding of the pathophysiology of depression evolves, we now know it's multifactorial, and that's exactly what goes into the mechanism behind Rejoin. MRI imaging has demonstrated that there's hypoactivity in cognitive areas like the prefrontal cortex and hyperactivity in the emotion centers like amygdala. We know the amygdala to be the fight or flight and emotional regulation center, and we credit the prefrontal cortex with cognition control, working memory, and its role in providing us more balanced responses, right? So that dysregulated connectivity is where we're targeting. That having been said, Rejoin is a 6-week program designed to target the neural circuits within the cortical limbic system and address the negative bias, or what we know to be the preferential processing of negative emotion information that we see in MDD patients. Our cognitive emotional training, or CET exercises, leverage the plastic nature of these circuits, in essence. Consider the CET exercises like physical therapy for the brain. They're repetitive, coordinated activation of these regions and aim to improve top-down cognitive control of emotion. Additionally, Rejoin does also have CBT mainstay video lessons. So how did we prove this? We set out to validate with a trial. Rejoin was evaluated in a trial called Mirai. Fun fact, Mirai in Japanese means the future. This was a fully remote, double-blind, randomized controlled trial. We screened within the first 3 weeks over 1,000 patients. 386 of those were enrolled, all suffering from major depressive disorder, all had inadequate response to treatment. It was monotherapy of an antidepressant, and that inadequate response was indicated as with having a HAM-D score of 18 or greater. The patients were randomized 1-to-1. 194 of these patients landed into the treatment arm, 192 landed into the control arm, evaluated during a 6-week treatment period, and then looked into again for a 4-week extension to evaluate durability of effect. The primary efficacy endpoint was the mean change from baseline to week 6 in MADRS total score in the modified intent to treat population for Rejoin versus cognitive training. So participants that were in the Rejoin arm received 6 weeks of treatment with working memory tasks paired to identification of emotions, as well as the CBT video lessons. The participants that were enrolled in the sham group were told that they were going to receive 1 of 2 PDT engagements. They underwent cognitive training because they had working memory tasks, but it only involved shapes. So they did not have to identify any emotions. There were no CBT lessons. Therefore, there was no triggering or firing off with the amygdala. The control arm was, though, just for reference, analogous to the active arm in terms of time, attention, and the participant's expectation. So intent to treat, there was 386, as I mentioned. Modified intent to treat. So in order to meet criteria for modified intent to treat, the individual would have had to have at least 1 treatment session, 1 MADRS assessment at baseline, and 1 or more post-baseline. Let's jump right in. So we found that Rejoin reduced symptoms without side effects. When we look at the mean baseline, they were very similar. So the MITT 28.5, 28.4 for the sham. We found that there was a 9.3 drop in our Rejoin group compared to the 7.25 in sham. We noted very similar in the ITT. So both experienced numerically greater decreases than the sham, and it gave us that evidence, right, that that the engagement with Rejoin, so that continued engagement enhanced clinical benefit. From a personal side, and as a pharmacist myself, obviously we all know that the most important party in the house here is the patient. So we know that the PHQ-9 is patient derived and gives us purview into what their perception of engagement with Rejoin was. Our randomization, again, was fairly excellent. I mean, we had baseline of 15.3 in MITT, 15.1 in sham. The MITT mean total score change in symptom severity went down from moderately severe to mild, which it's very exciting. I mean, that's a 2-category movement in 42 days. We see similar impact noted in the ITT group as well. Anecdotally, I think we can all recognize that that's the kind of change that you can expect to see in PHQ scores from an IOP setting at like a fraction of the time commitment for a patient. Additional findings, so Rejoin was found to reduce symptoms, full or partial response 51.3%, and a remission of 18.2% compared to the 13% in the sham group. Of note, remission is at least a 50% reduction in MADRS as well as a score of less than 10. Exciting stuff when you see rate of adherence 88.1 percentile and a patient reported satisfaction rate of about 76 percentile. The application and Rejoin takes into account life, right? So adherence is considered or is defined as 12 out of 18 treatment sessions being completed. When you think about the level of rigor and difficulty that the patients are naturally going to experience when taking on treatment of Rejoin over 6 weeks, the rate of adherence of 88 percentile is massive. And we can extrapolate that to consider how that impacts how they interact with their provider and the overall treatment protocol that they're engaged in. Of note, of course, Rejoin, there's nothing that they're taking in orally. So adverse events reported are unrelated to Rejoin. So upper respiratory tract infection, nasopharyngitis, headaches, they were seen in similar ratios in Rejoin and control, which makes sense given that they're not related to the intervention. So now you guys know exactly what Rejoin is from the clinical side, but what does Rejoin look like for your patients? Rejoin is 3 main pillars. The CET exercises, it is the CBT video lessons, as well as in-app notifications and daily motivational text messages. Of note, the patients are going to engage with this treatment explicitly via their smartphone. There is no iPad or computer formulation of this. It's just in the privacy of their home on their smartphone. So what you're seeing here, this is exactly what it looks like from the patient's purview in their home. So the lessons, right, the CBT lessons, these are self-directed. They're not therapist-based. The little persona that you see there is called Poppy, and that's what kind of directs them through these lessons. The CBT component is targeted to operate at a 6th grade comprehension level. The CBT lessons are formulated around the 3 pillars of behavioral activation, cognitive restructuring, and emotional regulation. In terms of commitment, you're looking at 3 lessons each week for 6 weeks, 18 lessons in total. Once the lesson has been completed, they can view it again in their learning tab. Some of the lessons will contain requests or possibilities for the patient to make changes and commitments based off of the lesson that they just completed. And they'll see that in a toolkit component. Please note that the patients can also engage with CBT lessons after the 6-week treatment is over for an additional 4 weeks. The exercises in treatment, the CET or EFMT exercises, are also 3 times a week. There's 15 rounds in each exercise, and they're for 6 weeks, so also 18 exercises in total. The engagement, the amygdala recruitment for the patient here is where they're going to have to identify an emotion of a given face in a running series of faces. The face options are happy, sad, disgusted, and surprised. Working memory component comes into play. So during the task, the patient must determine if the emotion that they're seeing currently matches the one shown N number back. Over the course of 6 weeks, it'll increase in rigor, so it goes from 1 back to 7 back. The app modulates and ebbs and flows based off of the patient's engagement or ability to complete them. Prior to beginning each exercise, the patient is made aware of the number back that they have to recollect. I will say setting expectations here is key. So the same way that I let you guys know that it's meant to be repetitive, it's meant to increase in rigor, patients really do need to know this as they take on Rejoin for 6 weeks. Without that setting of expectation, they can be a little bit confused or discouraged in terms of how well they are or aren't doing at the memory exercise. They're not meant to get 100% score. They're just meant to engage and really trigger both of those components of the brain simultaneously. Life happens, and the app takes that into consideration. The recommended treatment schedule is for the patient to engage with either a CET or CBT component each day with a day off. However, it's not always that easy to make that happen in your day-to-day life. And a big component of Rejoin is making sure that this fits into the patient's life. So an sample alternative would be to take on a CBT and CET lesson 3 times per week. Resources are available for both the patient and the provider. So in no way, shape, or form do we think that the provider in one session is going to explain everything to them and have answered all the questions. There's always end-to-end nurse support. When the patient opts in via the app, they'll receive a welcome call, help with onboarding, and they receive regular check-ins. The nurses are just meant to have a robust amount of clinical context, but they do not replace the provider in any way, shape, or form or give any kind of clinical support advice. They're just there for support. Conversely, providers can also reach out. We have multi-touch point support. They can call from 8 a.m. to 8 p.m., or they could use the chat feature 24/7 from the website. How do you get it in their hand or in their phone? Licensed prescribers can just simply e-scribe it to CarryRx. That's our online pharmacy that dispenses the codes. Behavioral health clinicians should feel just as empowered. They could refer the patient to the website. It takes them to Wheel. It's a telehealth provider, and for $29, it will send them an e-script after a quick evaluation over to CarryRx. Just for a quick reference, there it shows the CarryRx information and what the SIG should look like, right? So the product has an NDC. It should be easy to find both Rejoin and CarryRx in any of your e-scribing platforms. It's written for a quantity of 1. The SIG is used as directed. Simple as that. On the right-hand side, you'll see kind of the trajectory of how it looks for the patient. Patient's going to receive a text message from Carry to collect payment. The patient can use their FSA or HSA card if they so please. Once the payment is received, Carry will then send them an 8-digit access code. At that point, if the patient has not already, they can download Rejoin onto their phone. We usually recommend that the patient download during the session, the treatment session with their provider, the app already. When they download Rejoin via Apple or Google Play, whatever, and they put in that 8-digit access code, that starts the timer. And the 6 weeks of treatment begins at that point. So it's important for them to recognize that as well. Rejoin is $200 for the full 6 weeks. They do not have to pay any extra for the additional 4 weeks of CBT look back. And if you remember nothing else, here's the kind of overview slide. Rejoin is flexible. It's robustly clinically validated. It's safe. It's a temporary commitment. It's $200 for the full 6 weeks, and it's engaging. Thanks so much. Let me close out here so I can maybe see you guys and answer some questions.
Thanks so much, Coral. That was amazing. And again, applause to you for that great presentation. We have so many questions coming in. And let's get started.
Yeah, let's jump right
Again, this is very exciting.
in.
So, one of the questions was, what was performance on the working memory task also tracked and analyzed in the
So
trial?
the patient actually has the ability to monitor that themselves. So after each CET lesson, they get a score after each round. It's a complicated sentiment, right? So we don't want them to get 15 out of 15. The whole point is for it to continue to be rigorous and for them to be challenged. But yes, the patient has the ability to monitor how they're doing in the CET component at any given time.
Great. In looking at your satisfaction rates, they were very high, which was fantastic. Do you have a sense of what patients tended to like the most?
So the CBT components operate at a level, I mean, Poppy is cute, right? But it's
Right.
also CBT lessons that leave you with action items to follow through with later. Additionally, the CET component, as patients started to get more and more used to what was the expectation, there was high satisfaction of effect with low engagement time, or the fact that it was in the privacy of their home as well.
Okay. Yeah, so many questions here.
Yeah.
Did you see a difference in types of level of severity of MDD? And then secondly, any differentiation with the antidepressants that they were taking?
So for the sake of the trial, the patients could not change their dose or antidepressant agent. They couldn't have failed more than 2. They couldn't have had a history of suicidal ideation. So while the HAM-D scores had some variation, there had to be a minimum of 18, but they couldn't have been completely refractory to treatment. So all patients in the trial kind of fell within that
Okay,
parameter set's kind of tight.
sure. Now this is a big question. How do you define and think about engagement? I know that's, but challenging when we look at these types of products, right?
Mhm.
And so how did you all think about that?
Well, so we defined adherence as 12 out of 18 sessions. If the question is how do we define engagement overall with their protocols, that means continuity with their prescriber. That means refill adherence to their medication and continuing on it, and appointments not being missed.
Yeah, I think the one thing I would add is engagement from the nursing program as well. The ability to receive messages, encouraging messages as they are progressing through the treatment. So I think we find that personal touch really adds to the overall treatment for the patient.
And as far as obtaining the product, I think you talked a little bit about it, but then how do you support the patients that are using and then the providers as well?
So for that, again, we have the OCN team that's there to help guide should they kind of land themselves in a situation where the prescription was sent, but there's no access code entered. The OCN nurses can engage there. However, the providers always have the ability and utilize it, I would say pretty robustly, the chat feature to let us know if they're kind of experiencing any issues with CarryRx, or just not knowing where to send it, right? Sometimes it sounds like a great idea and you miss that last little detail. We do a lot of engagement with offices to make sure that they feel like it's the most streamlined process possible.
Well, I know that we are out of time and there are many questions left, but we will send them over to you. And I want to thank you both for this great presentation. It was wonderful, and it's good to see other products getting FDA cleared through the pathway. So appreciate your time, appreciate Videra's time as well today. So thank you all.
Thank you.
Have a great day.
Bye.